everybody, welcome to CHRs as community resources to help manage brain health. My name is Olivia Puamo. I'll be your moderator for this session. I'm a Kansas Public Health Specialist for the Southern Plains Tribal Health Board. And if you'll please use the chat to ask questions at the end of the session or within the last 5 minutes. Also, remember to review the chat towards the end of the session to find the evaluation link. So please take the evaluation link, the evaluation towards the end of the session. So you'll use the chat for that, and that will be in there shortly or towards the end of the session. So I'll let Keith get started. Thank you.
I believe Deborah Isham with IHS is going to go ahead and do the first few slides. Deborah, do you want me to go to the next slide?
I just want to say that in Indian Country, CHRs, as we know, are community health representatives, and this presentation is part of the Oklahoma Dementia Care Network. Next slide, please. These are our presenters this morning. Kirsten Reinschmidt is an associate professor at the OU Health Science Center. She's also been with the Oklahoma Dementia Care Network for the past 2 years, where she has led the development and training of the dementia curriculum for CHRs. She has worked with community health workers and more recently CHRs for the past 20 years. Since joining the OU Health Science Center in 2017, Dr. Reinschmidt's work has focused on CHR workforce development. Our next presenter is Terrence Gibson. These aren't in order as a presentation, by the way. Terrence Gibson is a research associate for the Oklahoma Dementia Care Network and Donald W. Reynolds section of geriatric medicine at OU Health Science Center. His work focuses on healthcare delivery and access for underrepresented and vulnerable populations, including patients with cognitive impairments and neurodevelopmental disorders. He joined the Oklahoma Dementia Care Network in 2019 as the co-developer of the Oklahoma CHR Dementia Training Curriculum and manages the evaluation of dementia activities for the grant. My name is Deborah Isham, and I work for Indian Health Service, where I've been the CHR coordinator since 2013. I've worked in Indian healthcare in both the federal and tribal sectors for over 25 years, and I'm a proud member of the Muskogee Creek Nation. Rob Kennedy is an LPN that works for the Choctaw Nation in the Healthy Aging Department, where he works as a case manager. He is a retired paramedic and worked at St. Francis Hospital in Tulsa, Oklahoma for many years. He's also spent time working at the University of North Dakota in the microbiology department for a virologist. Keith Plazinski is an assistant professor of research in the section of geriatric medicine at OU Health Science Center. He has many degrees, so I'll just move on and say that Keith is also the associate director for the Oklahoma Healthy Aging Initiative, a program housed in the section of geriatric medicine at OU Health Science Center. In this role, Keith oversees all of the health education activities conducted via 5 regional offices located throughout the state of Oklahoma. Our next presenter is Michelle Statham with the Alzheimer's Association. Before coming to the Alzheimer's Association, Michelle spent her career in service to Oklahoma citizens with over 29 years of service with the state of Oklahoma, where she served in the Department of Mental Health and Substance Abuse Services, as well as Department of Rehabilitation Services. After leaving state services, she continued her work in nonprofit organizations, serving as Director of Substance Abuse Prevention Services in Oklahoma County, and then as Director of Programs in the Cleveland County Habitat for Humanity. Michelle has a passion for and commitment to using data for evidence-based programs in evaluation and working with people to improve our communities. She humbly comes to the Alzheimer's Association in the hope that she can use her skills and commitment to serve individuals and families who are touched by this disease. Next slide, please. This morning, our learning objectives are explain how to maintain a healthy brain, describe how dementia affects the brain, list at least 3 available resources to help communities manage brain health, understand barriers to resources, understand how CHWs CHRs can help with access to resources. Thank you. Our content is divided into 3 parts. In this session, we will provide information on maintaining a healthy brain and preventing dementia, and on select resources available to manage brain health. We will describe how dementia training can help community health representatives, or CHRs, serve as resources for their communities to help promote and manage brain health. We will also share select resources available through the Alzheimer's Association, such as tips for informal caregivers and the Healthy Brain Initiative Roadmap for Indian Country. Participants will have the opportunity to share their knowledge of brain health, available services, and barriers to accessing services. So now I will turn over the presentation to Keith.
Thank you, Deborah. Appreciate it. Well, welcome everyone. Thank you for joining us today. We'll start with part 1, which, as Deborah mentioned, is the maintaining the healthy brain and preventing dementia. So one of the things that we're doing here with this presentation today is a little opportunity for you to give some feedback. And I went ahead and got an IRB clearance from the University of Oklahoma Health Sciences Center to ask some pretty straightforward questions, nothing very personal or intrusive. And I just have a quick consent thing I want to read to you about what we're doing here. I'm trying to conduct a study to gather data on perspectives from people such as yourselves on dementia or brain health and the caregiving of persons with dementia or brain health problems. So I'm going to ask you some questions. This is totally voluntary. If you don't want to answer them, no problem. If you do, please either chime in and unmute yourself or put an answer into the chat. And what I'm trying to do is use this as pilot data for a larger study on developing proper interventions for people who are either caregivers of persons with dementia or people with dementia, especially interventions that are culturally sensitive and culturally competent. And so the risks are very minimal for this study. The benefits are to help people such as yourselves, people such as the Southern Plains Tribal Health Board and other entities that we work with, IHS, Rob over at Choctaw, to offer resources and services to persons suffering from these issues. And so we are recording this, and we'll go back and use that recording just to make sure we got everybody's perspectives correct. My email is listed in this presentation towards the end, so if you have questions, you can reach out to me. And I just had to go through that spiel. So let me give a few minutes to ask you a few questions here. And again, if you would like to answer, either chime in or put your answer in the chat, and we'll save the chat as well. And you'll probably hear me typing some notes. But my first question for all of you is, how would you describe a healthy brain? What words would you use to describe a brain that is in good health? Don't be shy, there's no wrong answers. So Carol chimed in with, can engage in conversation oriented to time and place. Yes, thank you, Carol. Who else would like to chime in? I hear good memory here in the chat. Thank you. That's another good one. What else? I like that one. Keeping active. You heard Deborah say that I work with what's called the Oklahoma Healthy Aging Initiative. There will be a shameless plug for that later, but that's one of the things that we very much are interested in terms of the holistic health of a person who's aging is very important. Thank you. Thank you. What else would you use to describe a healthy brain? All right. So we've got one. Oh, we've got a more technical definition. So the healthy brain is getting enough oxygen and blood. Yes, we know that's important. And it's not being diminished by bad habits. Yes, that's kind of one of the things that I think you'll hear a lot about today. So those usual bad habits we often think of, things like smoking, drinking too much, and getting enough exercise, eating right. Thank you. Those are very good. We will definitely touch on all of this throughout the presentation. Then I've got one more here. Able to perform. If everybody's familiar with ADLs, I'll just prescribe real quick. Activities of daily living. So those things that most of us will take for granted at this point in our lives, that you can do those without difficulty. Thank you. And then one more, somebody who engages in activities on a daily basis that keep them busy and happy. Yes, I love that. Thank you so much. All right, let me ask you the next question. And the chat's totally great. Totally great. I do this for a different project here in the section of geriatrics. We get a lot of feedback in the chat. What behaviors can help, and you kind of talked about this, but let's ask this question again. What behaviors can help your brain stay healthy throughout the lifetime? So what would you say, and I know we kind of touched on this, but if you guys want to give me a few answers for that, that would be great. Behaviors that help the brain stay healthy throughout the lifetime. Education. That's one of the reasons why we are here today. Never stop learning. Very, very important. Thank you. Again, continuing to stimulate the brain. Very, very important. And I like these suggestions right here. Learn a new language. And I'll tell you, my background is in anthropology. And people who learn languages, and I bet you Dr. Reinschmidt could chime in on this, and anybody else on this who speaks another language, really activates both parts, many parts of your brain at once. So very, very important. I love learning to play an instrument. I grew up with a music professor father, so he would totally advocate for that. Exercise regularly, but it does not need to be intense. Yes. And we can talk more about that later, but that is very important. Body in motion stays in motion. Anything else? Keeping active. Oh, okay, this is great. We got a vignette here. 95-year-old grandmother who goes to an adult daycare and looks forward to that every day because they keep her active. So important. I love to hear that. Too often in our society, there's people who are older are thought of as not active, and that's absolutely false. I love to hear that somebody who's well into their 90s, still going out and doing things every day, keeping themselves happy, keeping themselves engaged. These are the things that keep people healthy. Thank you so much for sharing that. That's really, really cool. And I'll tell you, I have a mother-in-law who is in her 70s who still plays tennis. And I know that that keeps her happy and healthy. And that's really, really cool. So I love to hear these things. Next question. What behaviors can harm your brain throughout your lifetime? And we will talk about all this. This is just to get you guys to think, give us some feedback, then we'll go through all this. You kind of mentioned some of these things. Drugs, yeah. And I assume you mean drugs in the sense of like street drugs, but yes. And actually prescription drugs can do the same thing, depending on if they're prescribed correctly. Smoking, drinking, absolutely the usual suspects. Poor nutrition, yeah. And we'll go through this. So I want to get through the questions quickly so I can turn it over to Dr. Gibson so he can go through some stuff with you. One of the things that I think is important, and I think we've got a lot of people on here who are professional today, and we're doing these type of presentations with some folks in communities. In your own words, and you kind of did this earlier, but how would you describe or define dementia? And that may include signs or symptoms. Like, what would you say to somebody if you were going to define the term dementia? Okay, good definition. Cognitive decline that shows up in ways like losing direction, difficulty engaging in conversation. Good. My father-in-law had Alzheimer's, and these are all things that happened to him. Very, very tragic. Memory problems that affect your daily life. Yes. And we'll have more talk about this, that what are, and I think Michelle will go through some of this, what are memory problems that are normal and what are not. Unable to remember who, what, where, when details. Absolutely. My father-in-law started to confuse roles as he got deep into his dementia. So he thought my wife, his daughter, was his wife at one point. It was tragic. Mood swings, yes, hard to concentrate. Memory loss, good. And I'm just going to count these also as signs and symptoms, absolutely. Increasingly, yes, unable to take care of basic needs. Those are kind of those ADLs we talked about earlier as well, things that we may take for granted, cooking for yourself, getting dressed in the morning, things like that. And you guys give me a lot of signs and symptoms. So let me go to the last one, because I think this is important, because I think there's definitely a difference in the literature I've read talks about this, and just in my travels, in my work, this is something that I wanted to ask you all. How is dementia or brain health understood in your cultural background or your community background? Are there different ways of explaining what dementia is than maybe other communities explain how dementia is, what it is? Maybe I should give an example of kind of what I'm asking here. So if you think about like the medical understanding of dementia, you guys used a lot of the words that would be associated with that would be decline. Yeah. Okay, so here we go. Alzheimer's. So like Alzheimer's disease, people are not sure of the proper term. Yes. Confronting is very difficult. And I think that is one of those things that's cross-cultural. I know that many different groups of people don't want to talk about it, don't want to act like it's happening. Denial's huge, not understood, not talked about enough. Yes, these are great. Thank you. Just part of aging. I've also heard that, the circle of life. It's a return to another state of life. Older adult disease, but this is a good one, guys. But many younger people are starting to have these problems. And you're hearing more about early stage dementia being tied to people my age and not much older. And it's true. Now you're starting to, as people talk about it more, you're going to hear more of these stories. And it's different in each community, yes. And I like this. You know, for my own family, when my father-in-law got formally diagnosed, he was in his 80s. And here we take care of all of our family. We all take turns. Thank you. I appreciate the personal vignette. And one of the things I know from reading literature for people from tribal backgrounds is caregiving is an honorable thing. It's not a burden per se. And that may not be the same for every tribal group, but that's something that you read a lot about, that people who come from a tribal background view it as an honor, as something that you want to do as a part of your responsibility to your elders and those who predate you and your ancestors. So thank you so much for indulging me. I have 3 more of these little exercises. But I'm going to turn it over to Dr. Gibson to guide us through the next part of the presentation. And he will talk about the maintenance of a healthy brain and some of the things that we're going to start off with today. So Dr. Gibson, take it away. I think you're good to go.
Thank you, Dr. Klaczynski, and thank you all for the great responses. These were excellent. And actually, you all provided the answers that are a great segue to what I'm going to talk about. So I'm actually just going to unpack some of the things that you all mentioned. So when we talk about maintaining a healthy brain, I like to think of it as keeping your river flowing, right? Your heart is like the start of a free-flowing river. So you have your veins and your arteries that both take blood away and pump it back to the heart, that are all connected as small little streams that flow throughout your body, most importantly to your brain. And as someone said in the comments, right, all of that is feeding our bodies with oxygen and energy. And so we have work to do as individuals and the healthcare system to make sure that we keep that river flowing, our internal river flowing through our body in a healthy way that prevents it from being clogged from the heart into our brains so that we aren't doing any damage to ourselves. And the next slides. Thank you. And so maintaining a healthy brain in terms of working with our doctors, we know we want to help our clients, those who may be health professionals or CHRs, starting with making appointments to make sure that we have routine wellness tests and health screenings, preferably at least once every year. And those are usually free for individuals 65 and older who may already be on Medicare Part B, or through IHS as well, those annual wellness checks. Second, to have your blood pressure checked regularly and to know your numbers. A blood pressure that's less than 120/80, the top number, of course, being your systolic blood pressure and bottom being your systolic. Making sure that they're normal. So anything over 120 up in your numerator is considered too high, right? High blood pressure or risk for high blood pressure. And anything above 80 in the denominator is also considered risk for high blood pressure. So we want to stay below 120 and 80, 120/80. Asking our doctor how we measure blood pressure and how can we track our own blood pressure. Your clients and patients, helping them with access to resources that allow them to do so in the home, or at least having access in the community to check it regularly. Having our cholesterol checked is incredibly important, and also knowing those numbers as well. So making sure that we're talking to our doctors frequently to make sure that we know what we can do to make sure that our cholesterol isn't too high. And if it is, how do we combat that, right? How do we address high cholesterol? If we do have diabetes, making sure that our blood sugar and A1C levels are checked regularly, and to work with our doctors to maintain normal levels. And if we don't have diabetes, still having our blood pressure checked regularly, but making sure that our blood sugar is less than 100 milligrams, right? And lastly, talking with our doctors again about medications and vitamins, because we want to make sure oftentimes medications can increase our blood pressure, or at least our heart rate, and it can cause problems with our memory, our sleep, and brain function. So while it's not an intentional, the symptomology after medications isn't intentional, it actually, depending upon the use of medications, can increase our risk for dementia. So if we do notice that medications or prescriptions are causing problems with our memory, things like sleep, daily activities, or cognition, that we bring that to the attention of our providers as well. Next slide, please. Some of the things that we can do on our own, and you all mentioned every single one of these, right? Being active and walking every day. That physical activity helps us maintain healthy brains, but also healthy bodies, right? Eating more fruit. Someone mentioned nutrition, right? Fruits and vegetables, and reducing salt, which of course sodium increases our blood pressure, and sugar as well. Take our medications for blood pressure and diabetes regularly, even if we feel good. And I know that's a very important thing because I hear people say all the time, well, I feel good today, I don't need to take my medication. Regardless of such, we want to make sure that we maintain our medications as prescribed, right? So if they are daily, regardless of how we may be feeling internally or externally, that we maintain, in order to keep ourselves healthy, that we maintain that regular schedule with our medications. If you do smoke or chew tobacco, looking to our providers to help us with opportunities to potentially stop, because we know tobacco use and smoking not only increases our blood pressure, but also has many risks associated with cognitive decline and dementia. If you happen to be overweight or your clients happen to be trying to lose weight with physical activity, a healthy diet, and maintaining a nutritious diet as well. Read food labels to see how much sodium that we're intaking in our body, and that we want to stay away from saturated and trans fats in our food. Limiting alcoholic drinks is incredibly important. Excessive alcohol use, of course, as we know, can be very damaging to our brains. And so if that is a challenge in many of our communities or with many of our patients and clients, helping individuals be able to limit the use of alcoholic beverages throughout the week will help prevent the cognitive decline over time. And most importantly of all, of course, getting sleep every night. That's so hard for many of us, particularly those of us who have busy schedules, have a lot going on. Stress, anxiety, and depression also reduce our ability to get the level of sleep that we need, but our goal is always to get 7 hours a night. So we want to make sure that we're doing that as well in order to promote the best brain health we possibly can, and keeping our mind active. I saw in the comments someone mentioned keeping that stimulation, learning a new language, as Keith discussed, learning new skills, whether that be new cooking recipes, new card games, playing things like chess or doing puzzles. Anything that we can do to keep our brain stimulated also helps maintain a healthy brain as well. And I'll move to the next slide. So some things that we can do today, and this is really just to sort of summarize everything you all talked about, right? Calling our doctors, maintaining those annual appointments, talking about how we can keep our mind and our hearts healthy, scheduling those wellness checkups and health screenings, making sure that we're reducing the risk of cognitive decline or any impairments, dementia in particular. Getting a little exercise a day, a little physical activity, whether that be walking, whether that be playing with the kids or grandkids. Eating more fresh fruits and vegetables, of course, reducing our sodium intake, reducing our sugar intake, stopping smoking or chewing tobacco, maintaining a healthy blood pressure and managing high blood pressure if we have it, managing diabetes, high cholesterol, and depression or anxiety, all of which are risks for dementia. Protecting our head, right? We know as we get older, falls become the #1 cause of head injuries, particularly traumatic brain injuries as we get older. So making sure that we are protecting ourselves and our heads. If you're having trouble with memory or forgetfulness that make it hard to get through the day, we want to make sure that we're seeing our doctors right away, right? Because as someone mentioned, one of the common misconceptions about aging or dementia in particular is that it's just a normal part of aging, right? And we know that not to be true. And so I'll actually talk about that on the very next slide, if you can, Keith. So we talked about dementia in particular, and we'll speak a lot about that throughout the rest of the morning. And you all gave phenomenal descriptions of what dementia is. We know it to be a chronic condition, right, that affects a person's brain. And so dementia has a variety of different cognitive problems. You all mentioned them, right? Thinking, communication with our memory, carrying everyday tasks like cooking, everyday tasks like bathing, all of these things. Dementia does get worse over time, right? It is a progressive disorder. And so therefore it is not reversible. And so people gradually lose their ability to take care of themselves or to perform those ADLs, as Keith mentioned. It can be difficult to provide care for people living with dementia, especially when they need many hours of care over time. And so when we talk about Alzheimer's disease, dementia is sort of that umbrella term, right? Dementia is sort of a series of cognitive impairments. Alzheimer's is the most common form of dementia. So Alzheimer's disease is a type of dementia, by far the most common form that we'll see. And that's a particular disease that damages the brain cells over time. So it is a progressive form of dementia that over time disrupts our ability to make our cognitive connections that allow us to be able to function. Vascular dementia is also a common form of dementia. It's the second leading cause for dementia, and that's usually caused by our lifestyle behaviors. Smoking increases our risk for vascular dementia. Inactivity, so really not being physically active. All the things that weaken our river, right? We talked about our river. The blood flow to the brain usually causes vascular dementia. So we're going to talk about those two forms, particularly throughout the presentation, and why we need to be concerned about them. I'll go to the next slide, Keith. So how do we prevent dementia, right? And why is it important to? Our population of American Indians and Alaska Natives are growing quickly, particularly of those who are aging. So by 2060, that number is expected, those over 65, to grow 5-fold. That's not a lot of time. That's just 39 years from now to increase 5 times the rate it is now. And so we call this sort of the rose and the thorn, right? We love that we're being able to spend longer times with our elders and our aging population. And so the knowledge and traditions get shared, and we're enjoying spending that time for a much longer period of time, for a much longer period than ever before, right? We're living longer than humans ever have in human history. However, that also increases the risk of Alzheimer's disease and dementias. So it is the rose and the thorn. We love our rose in that we have more elders over time, but that comes with several risks as well. So, and that impact of dementia is multi-generational. People living with dementia gradually need more help caring for themselves, and that help tends to be the youth living in the family, right? Including help with daily activities, those ADLs, right? And so how do we prevent dementia? So we talked about many of those things, right? In maintaining a healthy brain. Nutrition, we talked about physical activity, reducing alcohol consumption, reducing smoking and tobacco. All of these things, maintaining a healthy blood pressure, managing diabetes if we have it. All of these things help us prevent cognitive decline over time and promote a healthier brain. Next slide, please. And so one very important resource we have is the Healthy Brains Initiative. It's called the Roadmap for Indian Country. And that's a guide for American Indians and Alaska Native leaders to learn about dementia and start discussions throughout their communities. And it's been very, very helpful for our community health representatives who've been working with the aging population as well, or caregivers. And this guide suggests 8 strategies that embrace the community strengths, including traditional practices, traditional tribal practices, resilient strategies, and existing services that can be tailored to the priorities within your communities. The CDC also has many great resources as well for aging and promoting healthy brains and reducing the risk of dementia. And also, of course, the Alzheimer's disease, which we happen to be incredibly lucky to have a representative here today to talk about some of the services that they do, but also how we can all come together to reduce the risk of dementia and what we can do to help manage that. And I'll conclude with the 10 warning signs of Alzheimer's disease I believe you all actually covered every single one of these, which was really cool to see, right? Memory loss that disrupts daily life. We talk about ADLs, forgetting events. Perhaps you notice people are repeating words. They're frequently relying on more aids to help people remember, using sticky notes or writing reminders on counters for simple daily tasks, right? Having challenges in planning or solving problems. Maybe that's something as simple as paying the bill or cooking a recipe that they've been using for many years. A third of which is difficulty completing familiar tasks at home for work or leisure. So as I mentioned, cooking, driving places, using something as simple as a cell phone, or even shopping. Having confusion with time or place. We know that's very common, right? Perhaps not knowing what day it is, what year it is, where you are. Trouble understanding visual images and spatial relations is a very common sign of Alzheimer's disease. That may be having difficulty with balance or judging how far something is, tripping over things at home, or perhaps there are more spills. Having new problems with words and speaking and writing, right? And communication, having trouble following a conversation, joining a conversation, struggling with simple words or to find a word that we're looking for, misplacing things and losing the ability to retrace steps is also a common sign for Alzheimer's disease. Misplacing car keys, of course, is common amongst all of us, but the frequency to which that happens is for sure a sign that perhaps some sort of cognitive decline may persist. Not knowing how to use a washer or dryer, or which room it's in, not being able to retrace one's steps. Decreased or poor judgment, of course. Withdrawal from work or social activities, maybe not wanting to do activities that they've been accustomed to their whole lives, like perhaps going to church, not wanting to go to the grocery store, or being able to follow a football game, or to keep up with what's going on in from their visual perspective. And lastly, changes in mood and personality. And so maybe you notice frequently people are getting more upset over very common situations, more suspicion or more fearfulness of things that typically what we would consider to be abnormal, right? So all of these things we know to be warning signs of Alzheimer's, things to keep up with, and we can provide that list for you all in your work. But with that, I will go ahead and pass that on to Deborah, and we'll transition to part 2 of our presentation. Thank you.
Thank you, Terrence. So part 2 is our presenters will share their knowledge of brain health, available services, and barriers to accessing services. So I'll turn over to Keith right now, and he'll ask some more questions where you can reply in the chat. Thank you.
Thank you, Deborah, and thank you, Terrence. Great stuff here. And yeah, as Deborah mentioned, now you'll hear about some resources. And so some of the questions I have for you revolve around that. And I just want to pick your brain a little bit before we go into the presentations. So are resources or services available to people with dementia and their caregivers in your community? If not, why do you think that's the case? If so, what are they? And it can be very brief and it doesn't have to be super in depth, but I just wanted to see what you guys knew in terms of what was out there that was available, if there is anything. Okay, memory centers that are tribal and trained group. Oh, I like this. Something called Purple Angels. Cool. Would you be willing to give me a little bit more information in the chat on Purple Angels? Because this sounds really interesting. Okay. They can assist someone in the store who's showing signs of confusion. That's great. That is great. Who is showing signs of confusion. And that's one of those things I think Michelle will talk about, is people who have maybe gone to the same place over and over again and now look lost, or as Terrence mentioned, you don't maybe remember where. Yeah, thank you. I appreciate that. If you can email me more about that, that'd be really great. Thank you, Carol. People will start to forget where things they always knew were. So then we hear, no, there's some people are currently working on a grant to start a program. So just now looking for resources. At the end of this, Beverly, if you grab my contact information, and then I think somebody just plugged in some grant stuff for you. There are some services out there, and I was going to say the same thing. There's actually a lot of grant money available. You just kind of have to find it as you're figuring out. And then we hear about Alzheimer's. We're going to hear a lot about the Alzheimer's Association. They do education, care consultations, and support groups. A lot of those things are online now, so people can be online, they can access them. They don't necessarily have to geographically be close. Sunbeam Family Services is here in the city, and Daily Living Centers, yes, they offer what's called respite care, which is something where you can get like a voucher to take a family member somewhere for a little while. And so as a caregiver, you can have some time to take care of some things for yourself, and lifespan grants through CAP. Or aging services. And another one I would look, I'll get my shameless plug in here. Thank you, Morgan. And Ojai offers some caregiver education as well. Another one, and let me put this in the chat that you might want to check out, and I believe it was Beverly was looking, is I think it's called the Administration for Community Living. And I have a grant from them, and I think that they're I'll get to this other comment here in a minute. I think that they have some funding available, so check that out. So no resources or services, and this is something you hear a lot. People are in denial. This is what I wanted to pick your brain about, and they're ashamed to talk about it. And yes, that's one of the reasons why myself and some colleagues want to take on a project to develop maybe something that can overcome that. In Norman, they have Full Circle Adult Daycare. Okay. So Beverly, it sounds like you're in the metro, and so calling Sunbeam and Lifespan and Aging Services might be worth your while. There's also something called the Caregiver Coalition, and I can link you up to that, or Morgan could as well, or anybody else, I think on the presentation here, and they have some resources as well. So you kind of gave me the answer to a couple of these questions here. And let me ask you this. Sounds like some people have accessed this. If you've accessed services and you're a caregiver of persons with dementia, please share a little bit about that. So I know people were talking about accessing some day services and things like that. If you could give me just a little bit of feedback on what that's been like for you, that would be great. So is it easy to access? Is it difficult? Are there time constraints, transportation problems, things like that? And I think this question is twice on my slide, so I apologize. And I guess I could give an example. So somebody earlier talked about OHI offering caregiver education, which is something we do, and I'll talk about it here in a minute. But we've been trying to move it to evenings and Saturdays so caregivers can actually access it, because during the day on a Tuesday is a hard time for people to step away. So personally not accessed, but worked with families who have. Yes, that's what I thought, some of you who would have experience in this arena in the rural areas. Yes. And even though we offer things, you know, considering the situation we've been in, we've tried to start offering things online. You've read probably, I wouldn't doubt at all, that internet access is a barrier. I was just going to say. And this is a problem well beyond Oklahoma. This is not unique to Oklahoma. It's something around the country that's a very serious issue. You've seen it with access to homes, you know, homeschooling during the throes, the deepest parts of the pandemic we've lived through. And you see it with things like this, where, hey, I can offer you a caregiver class on Zoom, but you have to have internet access, and you have to have good internet access in order to do so. Absolutely. What other experiences have you maybe had in terms of working with any resource service in your, not knowing where to start? Yes. And imagine you're sitting there with your older loved one and you find out this doctor tells you, okay, this person has dementia. They have this type of dementia. Let's say it's Alzheimer's. It hits you hard. And then now you don't know where to start because your life is, you know, irreversibly changed. And it is really difficult. It really, really is difficult. And it's a hard position to be in. Anybody else want to share any experiences with resources? I'll ask a little bit more about this later. I just kind of wanted to start talking about this as we transition into hearing from Michelle about the Alzheimer's Association, who has a ton of stuff to share with you guys, and also have a really cool presentation that will go over some of that. So I will turn it over to Michelle. Oh, wait, hold on. One more. Survive. Yes, that's a good one. We used to give that out here at OHI when we could give things out in person. An area-wide agency on aging is our local, what's called like a AAA office. So basically an area-wide aging office. They're all around the state. So depending on where you are there, and what's tricky is the names don't necessarily belie what they do. So for example, in the Tulsa area, or that northeastern area, it's called the Eastern Oklahoma Development District. That sounds like something completely different than an area-wide agency on aging office. So if you want more information on that, I'll try and plug some into the chat here as Michelle's talking, so you can kind of see where they are in your area, and maybe you can reach out to them. They have, like, again, the names are kind of different, but they are exactly what Beverly's talking about. And here in Oklahoma City, it's very simple, straight up, the area-wide agency on aging. So it's a straightforward name, but that's not always the case around the state. Michelle, I'm going to turn it over to you, and I'm going to dig up this AAA info while you're talking. If you want to go ahead.
Good morning. My name is Michelle Statham. I'm the Director of Programs at the Oklahoma chapter of the Alzheimer's Association. And we just wanted to make sure everybody was kind of familiar with who we are and what we do. So our vision is a world without Alzheimer's disease. And our mission is to eliminate Alzheimer's disease through the advancement of research and to provide enhanced care and support for all that are affected and reduce the risk of dementia through the promotion of brain health. And I think that interestingly enough, there has been some conversation around at least two of those things. But so research, care and support, and reducing risk is critical to what we do here at the Alzheimer's Association. And although my title is not particularly descriptive, Director of Programs, we focus on and are responsible for care and support. So under what we do, we have care and support. That is direct services out to people who have dementia, but more importantly, all of those caregivers out there that are trying to care for their loved ones. And we can talk a little bit more about what all that is. Concern and awareness. This is, of course, is raising the awareness of Alzheimer's. I think just in my short time here, and I am a short timer, Just the number of people who have very little awareness, if any, about Alzheimer's and dementia and how all that works and what kind of might be risk factors and so forth. So we specifically are targeting making sure that people understand that disease and how they can access services. Research is a big piece of what we do. There's also advocacy, and advocacy, of course, is when we access policy change and law change, healthcare change, because as we learn through our research and our data gathering, we also know that some of the most effective ways to help people with Alzheimer's is to make those policy changes. So we had that sustainability there. And then development or fundraising is the other piece of what we do here, because despite the fact that we would love that everything gets great support, that's not always the case, and fundraising is a piece of that. So next slide. So Oklahoma chapter, we do have chapters in every single state in the United States, and some states have multiple chapters. So in case you're listening outside of here, we have found we do get multiple states when we have Zoom calls. We have 2 offices here in Oklahoma, an office in Oklahoma City and an office in Tulsa. In other words, a physical location where you could walk through a door. But we also have staff located in Lawton and in Enid. And we cover the whole state. There's not a single part of the state that we don't cover with the services that we provide. The other thing that we have, which is fantastic, and we really highly recommend this as a first step for people who are sort of like finding out that first diagnosis or having suspicions about what's going on, is our 24/7 helpline. I have the number here, 800-272-3900. They are just a fantastic resource for people 24/7. If you're new on your journey, they can quickly begin to put you in touch with resources in your area, help you with a care plan, or even a plan for, discussing with your family how this might work and so forth. They're just an incredible resource. We hear wonderful stories about people who've been in touch with them and their professionalism. So that's a big resource that we have. We also have care consultations on site. So again, talking about those office locations in Oklahoma City and Tulsa, we do have opportunities for care consultation. So if you call the helpline first and they talk to you and they realize that you need to have a face-to-face with somebody, they actually refer that back to us, and we can meet with caregivers and persons with the disease. Support groups. Probably one of the biggest, most important things that we do is to have support groups for caregivers. It's interesting, coming from my background, I thought, well, educational presentations are, the bomb, and I love that, and I'm a data nerd in the whole 9 yards. But the truth is, when I got here, the thing I learned first and foremost was that support groups are the most critical thing that we do. And for caregivers, that is the piece they need the most. So we can talk a little bit more about that later. Education presentations. So that is kind of the core of what we do as a provider of services. So we have several education presentations, everything from understanding Alzheimer's and dementia, which we will do a very abbreviated view of here today. But we also do the 10 warning signs. We do legal and financial presentations for people who really are going to have to start providing. And this would happen even if you didn't have someone who is diagnosed. That would be a great one to go to. So we have several core program education presentations that we can do. Next slide. So I do want to make a plug in. It's interesting. So Terrence Gibson's information, a lot of that is going to parallel some of what I have here. I'll go into a little more detail. So the Alzheimer's Association and the CDC developed this Healthy Brain Initiative roadmap for Indian country. And I do have a copy of it right here. Some of you may have it already. But I also put aside about 5 or 6 extra copies. So whoever is running this, if you want to make that a resource available for people, you can either, may directly contact the Oklahoma Alzheimer's Association, or, and I see the link down there, or you can, I'll send some of those to our hosts, and they can have those as well. That is a fantastic roadmap. So yeah, and essentially it's tailored for leaders of American Indian and Alaska Native communities as they develop their response to Alzheimer's. There are 8 public health strategies that can inform and shape that response. And then we, as well as so many groups, and I know that you all are doing that here today, and we certainly appreciate being a part of that, which is encouraging discussing these strategies with your communities, involving your members in the planning, implementing community-wide approaches. Those things, just from my many years of work that I did in prevention, and sustainability is critical. And the only way you have sustainability is if you have awareness and you have buy-in. So it's really a big piece of what we do here. Next. So just quickly over the 8 public health strategies, working with community members to understand brain health and the early warning signs of dementia. Again, we're going to do a little of that today, but we do that really in depth. We can assist with that. Encouraging community members to use effective interventions, best practices, and traditional wellness practices to protect brain health. Providing information and tools to help persons with dementia and their caregivers respond to challenges that arise during the course of dementia. Dementia is a progressive disease, and because it's progressive, there's always going to be a new thing, whatever that might be, a new health concern. Well, now we don't have services that help here, or we were caring for them, but now we can't. They can't even swallow. So, really making sure that there's that continuum available for people. Promote engagement among your tribal leaders in dementia issues by offering information and education on the basics of cognitive health and impairment. And that is crucial. One of the things that the Alzheimer's does is, again, educates a core of volunteers so they can go back into their communities and be those educators. And I know we're talking about, community health workers and community health responders, and all of those can be trained around Alzheimer's and dementia so that can become more ingrained in your communities. Support the collection and use of data on dementia and caregiving. We don't have as much information on American Indian and Alaska Native populations, and we really do need to boost that. So that's something that we have in our roadmap of trying to make sure that we're addressing this issue properly. Promote inclusion of healthcare quality measures that address both cognitive assessments and the delivery of care of people with dementia. And so here's an interesting statistic. So as far as cognitive assessments are concerned, so 64% of caregivers say that they are uncomfortable with or need more information about cognitive assessments before they would feel comfortable doing those. And even less than that say that they bring that up as an issue, even when they think it might be one. So in other words, they don't introduce, hey, this is a part of what we do is cognitive assessment. You might be considering, or your loved one might be considering doing this given their age, given their risk factors, given some of the things that you're talking about. So they are leery and say, I wait for the family member to bring that issue up. Guess what? 91% of family members think the healthcare professional will bring that issue up. So as you can see, we've really narrowed the percent of people who are ever going to even talk about an assessment with their healthcare provider, let alone have an assessment. So I'm going to just sort of beat this, this particular fact because it's so important. If we can't get assessments done, if we don't recognize this, then we don't have any way of sort of intervening in that. Educate healthcare and aging services professionals in Indian country about signs and symptoms of dementia. And that again kind of goes back to making sure that people understand that information and can provide that information, but also to train a core of people who can then make sure they're providing that information out to just the general public out there in Indian country. And educating professionals on the best way to support families and caregivers with dementia, which I think is going to get a little more involved, but those are the 8 strategies they talk about. I think this is a fantastic document that we will happily share with anybody, and I do have some copies, so let me know if you want that. Next slide.
Okay, let me pull up the video or the electronic presentation here.
And as Keith is doing that, I'll just do a quick little plug for understanding the context we're doing this in. So understanding Alzheimer's and dementia is one of our core education programs that we can do. We have an hour version and a half-hour version. We're not even going to take a half hour today. I wanted to run through it to make sure we had that basic understanding. And a lot of it we've reviewed, so I feel like I can go through it pretty quickly and you're all going to have an understanding about that. But the other part is to let you know that we do have these programs, and they even vary in time and structure. So, all right, so understanding Alzheimer's and dementia. And go ahead and, yeah, thank you. Click on that for me. So learning objectives, I'm just going to go through the first couple. Comparing Alzheimer's and dementia. Sometimes there's some confusion around that. Some people think dementia is Alzheimer's, vice versa. Recognize how it affects, the disease affects the brain, and listing risk factors for Alzheimer's and identifying the 3 stages of the disease. Some of these we've already done, so pretty quick. Okay, so I'm just going to talk for 1 minute here on the impact of or on Alzheimer's, and talking about Alzheimer's under the umbrella. We have a video that normally does this, so I want to make sure, excuse me, that I cover this. Dementia is an umbrella term, and I believe that everybody that's already spoken has talked about that. Under that, you have Alzheimer's, which is the most prevalent form. So about 75% of all dementia is Alzheimer's. You have vascular dementia, which again, Terrence Gibson touched on, and I'm glad, because that again is a very prevalent form. You also have dementia with Lewy bodies and frontotemporal dementia. So several different kinds there. So this is a true false. I'm gonna go ahead and answer it so we don't have to have everybody, but approximately how many Americans are currently have Alzheimer's? And that's about 6 million Americans. There's a lot of people. Yeah, it's like 6.2, I think, is the newest number that we have out there. Yeah, more than 6 million. So that is, yeah, frightening. How about Americans providing unpaid care for people living with Alzheimer's and other dementias? Go ahead and click the next one.
Which one is it?
Over 11 million, I think. Now that
That would make sense. About 2
totally blank. I
people.
was like, yeah.
No, that makes sense. Sorry.
Yeah,
Okay.
No, you're fine.
So skip
All right.
this one.
Yeah. All right. Yeah. I'm trying to stay very. There we go. Alzheimer's. Is it a normal part of the aging process? And we've talked a little bit about this, but again, when we do a general education, you would be surprised at the number of people. And quite frankly, I come from a very rural part of Oklahoma. And so, you know, I talk to my parents, and I talk to my friends, and I talk to people out there. People think that's a part of the normal process of, well, you know, if you get old, you'll get Alzheimer's. Well, that's not true at all, of course. That statement is completely false. It's actually brain disease that causes a lot of memory problems, and it has a particular structure to it, right? So people younger than 65 can in fact get Alzheimer's. That is something that we also like people to know. It's funny, I actually find that most people think Alzheimer's does happen to people younger. They think the most prevalent kind of Alzheimer's is through genetics, which of course is not your biggest risk factor. Genetics is a risk factor, as well as our healthy lifestyles, like we talked about over the last 30 minutes, but age is the biggest risk factor. So people need to know that just because you haven't seen that in your family doesn't put you at risk for Alzheimer's. Go ahead and click through, there you go. That's a really good video, by the way. Someday I hope that you can see the full video here. So, just a short recap. Dementia is a general term for a collection of symptoms that are severe enough to interfere with your daily life. And I think we have had a good discussion around that so that people can kind of have a grasp of what that means. Alzheimer's is the most common cause of dementia, and Alzheimer's is not a normal part of the aging process. It is a progressive brain disease, and we hope someday that we can cure that. Go ahead. There we go. Again, that's a really good video too. I really like hearing from him on the history there. Okay, so more than 100 years ago, Dr. Alois Alzheimer described specific changes in the brain, the formation of plaques and tangles. And I think that's important for people to kind of know. It causes nerve cells to die, which leads to shrinkage in the brain. And those brain changes result in changes in memory, thinking, and behavior. And eventually it even results in things like not being able to swallow. And you do and can, you can and do, people do can and do die of Alzheimer's disease. So I think that's, most people think you don't die of Alzheimer's, you just get old enough, you finally die, but that's not true. So risk factors, and these we've talked about a lot. I've even gone through that, so you just skip over that. Age is your biggest risk factor, but family history, genetics, and we know more and more we understand that behaviors, and I can't press that enough because I want people to know that they have some influence on this disease. So behaviors are important. So populations at higher risk. Hispanics are about 1.5 times as likely as whites to develop Alzheimer's and other dementia. African Americans are about twice as likely to develop the disease as whites. And I will just say, I think we need a lot more data on the American Indian and Alaska Native populations so we can kind of see how that risk factor plays out. I might make a shameless plug for our science app here in a minute. Almost 2/3 of Americans with Alzheimer's are women, which people say, well, you know, women usually get older than men, so that's a part of it. And it is a part of it, but that doesn't account for the size of the difference. So that is one of those things that we really are still looking at, trying to figure out, you know, why does this happen? Is there some sort of, you know, genetic difference? But yeah, about 2/3 of women in America are Alzheimer or have Alzheimer's. All right, so age is the greatest known risk factor, particularly after age 65. Family history is also a known risk factor. Having a parent or a sibling with disease increases your risk. Risk genes and deterministic genes are the two types of genes that was covered in one of the videos. It was just a little in depth for what we're going to do here. And of course, we know, as is true so many times about all healthcare issues, Hispanics, African Americans, and women's are at increased risk for Alzheimer's. So stages. All right. See if we can, yeah, this one I'm not sure. Go ahead and click through.
I think it's right here.
Yeah, here we go. There we go. Yeah. Should appear here on the side.
There we go. Okay.
Yeah, okay, thank you. I thought it popped up on that other one too. So there are 3 stages of Alzheimer's disease. There's the early, middle, and the late. Sometimes we also talk about those as mild, moderate, and severe, particularly if you're talking about in the medical community. So early stage is a person may function independently, but people who know individual may notice subtle differences. I remember hearing a story one time about this woman who cooked for her family, wonderful cook. There was a dish in particular that everybody loved. She guarded the recipe. And then one day it started tasting a little different. You know, they get together as a family and it didn't taste quite right. And the next thing they know, she couldn't remember how to bake this dish that was like a family tradition. And I thought, what a strange and difficult way to find out. But people who were close to her knew early on because of these sorts of behaviors. Mild stage Alzheimer's is usually the longest stage. It can last for a lot of years. And as the disease progresses, the person will need more help. And in the middle stage, things might be like forgetting your own personal history, repeating things over and over again, frustrated and angry. And usually that is because of those things. They may not say that, they might not even understand that, but that is what's starting to cause that. Confusion about where they are in their day or the day of the week, particularly for people who've been punctual, that might be a real sign for you. Changes in sleep patterns will occur here. So even if you're aware that you have that and you have a caregiver there, that can be rough on everybody because those kinds of things begin to really change. You might also start to notice personality and behavioral changes at this point in time. And then of course, there's late stage Alzheimer's where major personality changes can happen in this particular stage. The person will need lots of care just in daily activities, personal care. They may completely lose awareness of their surroundings, where they are, who people are. They may even begin to have trouble communicating. And of course, get trouble. They begin to be higher risk for other diseases too, just because their limited ability and the degenerative part of that disease. All right. So no two individuals will experience these symptoms and progression of Alzheimer's disease in the same way. It's interesting. I have a caregiver whose loved one has passed away, and he's famous for saying that the first part of the disease is hardest on the person who has the disease, and the last half of the disease is hardest on those who care for them. And I think that is true if you talk about progression of symptoms and progression of the disease. So some people will say we had no idea that it mild, and before they knew it, they were in late stages. But that just is very, very different. On average, people will survive the disease, average 70 years, about between 4 and 8 years. But they can also, I know heard lots of stories of 11 years, 20 years. So it just depends. So while symptoms worsen over time, people progress through the stages at different rates. So next slide. And yeah, I'm just going to go ahead and skip through this because I think that unless you say you want me to talk a little bit about the newest, latest drugs, there are a couple things you need to know just in the very end of this, which is there is no current treatment for Alzheimer's itself. But that is no longer true. You may have heard about aducanumab, or it's being marketed under Aduhelm. So that is the first drug that's actually out on the market for use that is addressing the disease itself. Otherwise, we have these drugs here that have been in play for quite some time. And I'm not even going to try and pronounce all of those words. I'm not well versed enough at that to do that, except to say that they treat some of the symptoms of Alzheimer's disease. So that is, those are important things to know. You need to talk about providers or with your providers about this, but those are not exactly, those are not cures for the disease. Next slide. We're about to got 1 or 2 to wrap up here. All right, so I just will say here, here's where I will make my my plug for a couple of things. We do have clinical studies. So trial match, this is an important piece of what we do. We encourage everyone to go out to trial match. It's out on our ALS website. Here we go. Thank you. Trial match, it's the bottom one there, alz.org/trial match. It's free clinical studies, and we match people to services. So looking to see if there are services that meet your need, your loved one's need, where you are, what kind of disease, where you are in that dementia. Science has obviously increased our understanding of Alzheimer's significantly over the past decade. People living with dementia, their caregivers, and volunteers without dementia are needed for clinical studies. So just know that there's all kinds of studies going on out there. I had a caregiver just call me day before yesterday, and she is in her part of her life where she's ready to join one of these. So we are connecting her with some of that. And then both drug and non-drug studies are taking place across the country. So alz.org/trial match, incredibly important. Next slide. All right, so just again, letting you know that we're available wherever and whenever you need reliable information and support. So I am going to just answer a question that I almost always get when I'm on Zoom. And that is, yes, we're in every single state, no matter where you are in the United States, we have somebody that can cover you for all of the services that we've listed throughout this. But also there's that 24/7 helpline, 800-272-3900. We are online at alz.org, and you can find your organization if you want to. And we're in communities nationwide. And that's alz.org/CRF. It's so such wonderful services that we have. Next. All right.
Is that the end, or is there more?
No, that's it. I will just say,
Okay.
if you are interested in the science, also out on alz.org, we have Science Hub. You can actually download the app onto your phone if you're a nerd like me, and you can keep up with some of the latest Alzheimer's research that's going on out there.
Okay. Thank you, Michelle. We appreciate all that information. ALZ.org is the easiest way to start with that. And then from there, you can find your state and local offices. And they really have a lot of really good services that are available to people. And similar to, and some of the things we talked about earlier, some of those services are available at off hours. So hours that are not traditionally when people offer a lot of services, which is really important for caregivers. And that's one of the things we want to touch on here before we transition to the meat of the community health representative role in terms of dementia and people with dementia and their caregivers, is the Oklahoma Dementia Care Network is very much interested in taking care of the caregiver. One of the things you can find, unfortunately, in caregiving situations is that a caregiver who does not take care of themselves can pass away before the person being cared for. That's not common, but it's not uncommon. Our website will tell you about something called Powerful Tools for Caregivers, which is a class that's offered through OHI, but OHI is part of the Oklahoma Dementia Care Network. And Powerful Tools is a 6-session class once a week that helps you take care of yourself as a caregiver. So if you have somebody that is a client of yours who has a caregiver who seems stressed or burdened, I mentioned earlier that that literature, especially with American Indian caregivers, shows that caregiving is a positive thing. It's considered an honor, but it also shows, literature shows that American Indian caregivers do still experience a lot of burden, a lot of stress, and a lot of the things that also come along with caregiving for people in other populations. So this will help them learn how to reduce stress, improve their self-confidence in caregiving, managing their time, bettering communicating their feelings, right? It's a class with other caregivers. So then people can feel good, feel better about maybe if they have a negative feeling, other people may have that same feeling and they're not alone. Powerful Tools also helps with resources and helps you make tough decisions. You got to take care of yourself. So either go to, actually I would go to ohi.org, www.ohi.org. And let me plug that into the chat real quick for you. And then from there, you can find out where the class would be for somebody that may be in your client or a case management load who would benefit from something like this. I have 2 more things of questions, but I just have one here that I want to go into before I turn it over to Kirsten and Rob Kennedy to go through the CHR chunk of this presentation. And really, we talked about some barriers. I know some of them are internet issues and things of that nature. And in the chat, if you can either plug in some barriers you can think of that inhibit people from accessing services, and then ways those could be overcome. But really for me, if you could quickly tell me maybe 2 or 3 sentences, how you would have a resource available for people of caregivers or for caregivers of people with dementia, like how would that work and what would that briefly look like? So again, if you can tell me about some more barriers, how those barriers might be overcome, and then if you had a program, what might it look like? Okay, here we go. If there was more of a team approach and better integrated services, yes, I like this. Each family could get a personalized support to how to keep their loved one at home safely for as long as possible. This is right in line with what OHI is all about, which is keeping people as independent for as long as they possibly can be, so they can be getting the most out of life as they can. And I love this personalized support. That would be great if somebody could sit down and really design something that works for your family. And then transition that person to the next level of care like that when necessary. Keep them at home as long as possible. So that there is a movement going on called the 4 M's. And it is something that focuses on healthcare systems. And it focuses on mostly primary care doctors, geriatricians, whoever an older person sees for their primary care. And it's called the age-friendly movement, centered around what's called the 4 M's, which are mentation, medication, mobility, and what matters most. Real quick, medication is managing medication safely, right? Helping people stay as independent as possible and making sure what they're taking is helpful to them, which generally it is, but sometimes there's an interaction that can be not good for the patient. Mobility, we talked about falls, staying mobile, staying balanced, staying active so you can live independently. You don't have to worry about falling. Falling is a major issue for older adults, and it really derails healthy aging. Mentation is what we're talking about today, cognitive decline and dementia, but what matters most. And what I've just heard here about a team approach is kind of the what matters most, is where a provider will sit down with an older adult and say, what do you want out of the last so many years of your life, or this period of your life that you're entering into? What do you want to do? Is that gardening? Is that hanging out with your family? Is that, I don't know, walking to the pond with your dog? Whatever it is, what that provider can do to keep that adult as independent as necessary as long as possible, so that like what's being said here, keep them at home and keep them happy and keeping them enjoying those last years of their life as long as we possibly can, as opposed to just keeping somebody alive, right? Which I think we could probably all agree is a pretty good thing. I have one more question, Deck, but it's really pertaining to all of you as CHW, CHR persons or persons involved in that world. But I want to turn it over to Kirsten and Deborah, to go through this next section, and then we'll come back to that here in a minute.
Okay, our part 3 is how dementia training can help CHRs to serve as resources for their communities. And I'll turn it back to Keith, actually.
So, yeah, that came quicker than I thought. Thank you, Deborah. When you think about your role, if you are a CHR or you're somebody who manages them or you are involved in their world, what can a CHR do to inform the communities that they are serving about dementia? And what can they do to inform those community members about dementia prevention? I know somebody has a good answer to these questions. So what could a CHR help do to inform the community they work in about dementia and dementia prevention? Okay, 10 warning signs, so people know what to look for. Survey, yes. So one of the next steps for what we're doing here is exactly that, is to ask people what they know about dementia. I tried to design some questions because I thought you all generally know more about these things than maybe the average person would. And so that's a very, very good point, is to understand exactly what do people know about dementia. We do know that health literacy is kind of low, not just in Oklahoma, but around the country in general. And it isn't necessarily people who are of racial ethnic minority status. It's all people. Like half of the United States adults don't really understand what doctors tell them. So they may not understand even what a doctor is talking about with dementia. And then how could a CHW, CHR help those persons locate, access resources? Maybe the caregiver. How could they help those caregivers of persons with dementia get locating, accessing resources, and overcoming barriers? if you had a client who was a caregiver of somebody with dementia, there you go. Yes, exactly. A resource guide available. Knowing and sharing. Yes, get the resources and services directly then on the spot via the phone or online. Good. Anything else you can think of? Yes. These are big issues. Thank you so much for indulging me. I appreciate it. I want to turn it over to Rob and Kirsten. I've taken a little bit of their time to go through their section of the presentation, which I think is really relevant to most of you today. And Kirsten, I want to turn it over to you. Thank you all so much for dealing with my questions. I really appreciate it. And Kirsten, Rob, I'm here to guide the slides. Just tell me what you want to do.
All right, thank you very much, Keith. It was really fascinating to not only listen to the presentations, but also see all of your comments, because they feed right into the training that we developed. So Rob and I want to talk a little bit about the work that we have done to help answer some of the questions that Keith just asked. And they are all relating on how community health workers or community health representatives can serve as a resource for dementia prevention and dementia care. So in 2019 and 2020, we worked with several organizations that had expertise in dementia and also that employed community health workers or community health representatives. And we worked together to design a dementia training for community health workers and community health representatives. And here on the title, you see the people involved and also the title of the training. So we met several times to learn about the dementia-focused materials that already were used by Oklahomans, the CHWs and CHRs in their practice. And we also asked them, what kind of educational materials do you need? And we reviewed the existing educational materials and also adapted them to develop the new materials and training evaluations that goes along with the training. So our training has basic information on dementia. So basically what you heard today, that information is included and more details in addition to that. And the training also focuses on the community health worker or community health representative roles and skills that are specific to addressing dementia, and additional educational materials and resources from especially the Alzheimer's Association are also available. So we used a lot of materials from the Alzheimer's Association because it's great. What can we say? It's great material and it's very useful and educational. So we used and repackaged it in our training. So the first draft of the training that we had completed, we used to pilot it with 12 individuals that were CHWs and CHRs, and that was an 8-hour workshop. And just as now, this was a virtual workshop over Zoom. So then we received feedback after the training and revised the training. Since that first training, some of the CHWs and CHRs that were trained on the curriculum have given 3 trainings to their peers. And Rob Kennedy, whom you will hear soon, is one of the trainers that have been working with us. So over the next year, we're planning to hold 3 more of those trainings for CHWs and CHRs. Next slide, please. The dementia training for CHWs in Oklahoma was developed as part of the Oklahoma Dementia Care Network that started in 2019. The overall goal of the OKDCN is to provide Alzheimer's disease and related dementias education and training to Oklahoma's healthcare and public health workforce. And we want to do that to maximize the patient and family caregiver engagement and also improve the health outcomes of persons who live with dementia. So the specific goal of the training we developed is to deliver dementia care education and skills to CHWs in Oklahoma. Because we know that the CHWs or CHRs who are trained well on a specific topic, in this case, dementia and Alzheimer's, can support their clients and their families and communities very well, and they will help improve the quality of care for people living with dementia. And they will also help improve the quality of life for their families, and they can play a role in providing or creating a dementia-friendly community. And you'll hear a little bit more about this in a second. So the training uses, by using Alzheimer's disease materials, but also other materials such as from the Centers of Disease Control. So we are using evidence-based materials, but we acknowledged in the training as much as we could the diverse needs of the diverse communities in Oklahoma. And it's also designed to be interactive, so it's not just a lecture material, but to get the feedback and input from the CHWs and CHRs who have a lot of experience already, and by this format can train or help educate and support each other as well. So the entire training is 6 to 8 hours. And an additional 2 hours will give individuals the train the trainer dementia certification. The next slide, please. Okay, you may have heard me say CHWs and CHRs, community health workers, community health representatives. And so I wanted to make sure that I address why I'm doing that. So community health workers in general at the national level as well is used as an umbrella term for diverse members of the CHW workforce. And so they have many different names because they are very diverse from diverse communities. So in your case, CHRs or community health representatives is the correct term. In other communities, they might be called promotoras de salud, health promoters for the Spanish-speaking communities, or they might have titles related to the work that they are doing, such as outreach workers and patient navigators. So all those different titles, and there are many, many titles, they all are captured under the umbrella term of community health worker. So the CHWs, using this as an umbrella term now, they work with the diverse populations in a variety of diverse community and also clinical settings, and they play a number of different roles. And the diverse roles that they play and their diversity does not mean that they are not one workforce. And there is one definition of CHWs that is cut and pasted here on the slides. That is the CHW definition from the CHW section of the American Public Health Association. And according to that definition, CHWs are frontline public health workers, and they are trusted community members and do have a very close understanding of the community they serve. And because they are trusted by the community members, they are able to establish trusting relationships that help them to serve as a link between the community members and the social and health services that community members need to access and get services from. So community health members have community health workers have the capability to build individual and community capacity by teaching people, by giving them knowledge of specific diseases or resources in the community and help them take care of themselves. And they do this through many different activities such as outreach or direct education or other activities. So in the past, we heard a lot, well, is it really a one workforce? Because they are so diverse, we can't compare them, they're not the same. So in recent years, CHW advocates and CHRs included, allies, public health professionals, they all got together and conducted a national study and that is known as the Community Health Worker Core Consensus Project, or in short, the C3 project. And so in this consensus building, they came to the consensus that there is one workforce that is characterized by a broad spectrum of roles and competencies, and that in furthering and supporting the workforce, all the roles and all the competencies should be acknowledged and trained upon. So the next slide, please. So here on this slide, you see the core roles of the CHWs, and you can see there are 10 roles, and I'm not going to read them. But so those are the 10 roles that comprise the broad scope of practice for CHWs. Usually a CHW does not perform each of the roles in one position. So they will perform the specific roles that are needed by their employers and also by the communities that they serve. And some of the roles that you can see here may be added on temporarily as needed. So that is why it is important that CHWs need to know about all the roles and learn about the roles and learn the skills that are attached to those roles. So the C3 scope of practices, as you can see it here, is descriptive and not prescriptive or regulatory. But it means that, as I said, have people trained in all of the roles so that they are flexible either within the position that they already hold or within future positions that they might take on. So I'm talking about this with a little bit of detail because the training that we developed for dementia uses the 10 roles to talk about how CHWs or CHRs can address dementia based on those 10 roles. And today we just want to talk about 6 of those roles. And so for each of the 6 roles we want to talk about, I'm going to give you the role definition, and then Rob is going to tell you in more detail on what we came up with, what the CHWs can do. So the next slide, please. Okay, so I'm going to start out with the first role. And culture is really an important part of community health representative professional activities, and it plays a large role in the care of people living with dementia. So understanding the unique cultural characteristics of the communities served can help facilitate improved health outcomes and the quality of care delivered by the clients. And this is, I think, what Keith asked you a question earlier about, what are cultural specifics in your community as related to dementia? So the C3 project defines the first role as cultural mediation among individuals, communities, and health and social services. And they say that this includes educating individuals and communities about how to use health and social services, educating systems about community perspectives and cultural norms, and then also building the health literacy and cross-cultural communication between and among the communities and the healthcare professions. Okay, so with that, I'm handing it over to Rob.
Thank you, Dr. Kirsten. We have several links in our communities, and we need to use them as wisely as possible. And when we go to the clinics and stuff, we have to be aware of the HIPAA and labeling and so on and so forth. So we have interpreters that can actually go along and accompany these people because the services during the clinics are a positive visit. Being with the physician and having the individual, the physician may or may not really know that patient well at all. So it kind of helps the physician if you can prompt them in what activities or answers to some of his questions would be. and each family member will probably say a different thing as well. So if you can try to be consistent with that family member that always goes to the clinic with them, that really helps. As far as the client's goals and service needs, everyone wants to be in a healthy state. And setting the priorities as far as your ADLs is a +1. But knowing and keeping all of these going with dementia and stuff, that becomes even more of a problem, because it depends upon what level that individual is. He could be mild, he could hide dementia in the first stage or so. Nobody wants to be labeled, and so they probably will cover it as much as possible. But you can coach the client in what the physician is trying to ask. And that is sometimes important as well. And then when the physician has a definite plan and you've got to educate the person with dementia, that becomes a very difficult task. That's when you come and you pull in your resources and you try to get everyone involved and on the same page. Again, encourage training with cultural awarenesses. Everyone comes from a different background. There are taboos out there. Clients, if they can sort of remember, that helps. That's a plus. But when it gets into the serious part where they will not remember anything and are constantly being redirected, that becomes even more of a problem. You can, some people have access to entered notes. Everyone wants to be as brief as possible. Nobody wants to be labeled again. And reach out to all of the activities. The activities for dementia is to bring back the history, the pictures, everything that he can or she can relate back to. And the quality of care of the needs in this population is to be well rested. To have a rested brain is a very healthy brain. Back to you.
Thank you, Rob. So culture plays a large role in how we understand, interpret, and also value the new information that we get. And this is what role number 2 speaks to. This is about providing culturally appropriate health education and information. So that includes conducting health promotion and disease prevention education in a manner that matches linguistic and cultural needs of participants or communities. And it also includes providing necessary information to understand and prevent disease and to help people manage health conditions. And now it's back to you, Rob.
Thank you. There are 10 signs and symptoms of Alzheimer's diseases if they do not hide them on you. Memory loss that is disrupted daily. People will clutch about it and try not to be overt in how they do things. And challenging and planning, solving problems like getting your breakfast in the morning or getting your clothes arranged or what shoe to wear on a warm day or cold day. That all interacts into the difficulty that they may have been doing for a long time. Knowing just exactly the time and place where they are at, they may be in a different world. Some of them are in a different world, and you just have to work with them, and hopefully keeping the safety of that individual is probably the highest, most important thing. Trouble understanding visual images, spatial relationship, being around other people, being in a loud area may not be a wise decision. It may be too taxing on their brain. Misplacing things, losing things. Guess what? That starts at an earlier age for all of us. We try to limit that as much as possible, and we try to decrease or use poor judgment. But we all fall into those cracks, and it is hard not to at times. You can withdraw from work in social items because you can see yourself and you may not fit in. And if that is it, they will withdraw. They may have a mood change, and changes are with personality. And that is a key word, because dementia kind of will let you see what may be happening or what could happen. There are misconceptions about dementia. Alzheimer's diseases and dementia are the same. No, they're not. People living with dementia don't understand what's happening around them. Yes and no. That can be up. I can reach out. Does anyone out there have an answer? You can add it to the chat line if you would like. All right, dementia. I think it depends on the stage of dementia. That is true. That is most definitely true, because at an earlier age, they can probably deal with it a whole lot better. In a later stage, you probably will have a difficult time with them. Dementia is not fatal. Anybody have an answer? It can be, yes, it is fatal. It can be. It all depends upon what activity they're doing, if they could hurt themselves or if they would be in a position to hurt others. But usually you will try to keep the individual contained to the point where he won't hurt himself or others. And only older adults can get dementia. You know, it's in this world, a lot of things happen for different reasons, and we've seen dementia at a very younger age, and it all depends upon what they're doing with their diet and what they're taking for medication or for street medication, whatever their needs fits. And I will turn it over to Dr. Kirsten.
Thank you very much, Rob. So now we are in role number 3, and I will just mention what the role is. And I think for the sake of time, we move on to the next role. So Rob, when I'm going to jump from role 3 to role 4, and then you would jump in after role number 4. Just giving you a heads up.
Okay, thank you.
So the third role is very important ones for CHWs and CHR in their work. It is care coordination, case management, and system navigation. And I think from your experiences, you can see how that becomes important for people living with dementia and also their family members, as there are many different aspects of the disease and the everyday life circumstances that need support and needed. So there will be complex situation for people to request and need help in taking care of their loved ones and also of themselves. And so with that, I would like to jump to role number 4. Keith, that means for you hopping over 3 slides, I think. That's correct. Okay, thank you very much. So the trust that is built between the CHRs and their clients enables CHRs to provide coaching and social support. And the C3 project defines providing coaching and social support as giving individual support and coaching, motivating and encouraging people to obtain care and other services, and supporting self-management of disease prevention and management of health conditions, and also planning on or leading support groups, so that CHRs are leading support groups. Role 4 is one of the core competencies of the CHR profession, and in a way, CHR naturally play a variety of social support roles that range from being a confident person to a peer mentors for their clients. So with that, I'm handing over to Rob again.
All right, thank you. Emotional support. CHRs can encourage their clients to take some actions, definitely. CHRs can involve them with other organizations or meet with their families to see if it can be done by bringing them to other events and so on and so forth. That is very important because that also provides a healthy brain with the emotional support. Social support as well, if they are around people they know and that are able to reach out to them, allowing people to express positive or negative feelings about coping. Well, but the thing is people have to kind of understand that it may be a special situation as well too. So if one can adjust the challenges of the progressive illness like dementia, because they need to be able to have the people that can be very supportive as well. CHRs can lead both the supportive groups and caregivers by incorporating other people and professionals as well. Coaching may be the model of appropriate ways to respond to the challenges of behavioral and helping the clients and their family find the balances in their lives and the ways to prioritize their self-care needs. And if you can keep familiar faces and so on and so forth, that is definitely going to help the individual living with dementia. Back to you, Dr. Kirsten.
Okay, thank you. So CHRs can support clinical operations by providing direct clinical and community-based care. According to the CU3 project, providing clinical services includes basic screening tests such as height and weight or blood pressure, providing basic services such as first aid or a diabetic foot check, and meeting basic needs such as direct provision of food and other resources. And again, I would like to, Rob, I apologize for that, but I want to skip over that slide and move to role number 8 to give you a chance to talk about that as well. So in role number 8, this is about implementing individual and community assessments, which is defined as participating in design, implementation, and interpretation of individual level and community level of assessments. So Rob, if you want to talk about our last slide, that would be great.
All right. The personal hazards, managing the medication, so true. Some of the medications might make their dementia worse. So you're going to have to be careful with their side effects on the medication. Driving, that is a very sensitive area because people with dementia probably should repeat their driver's education class. I don't know. Wandering and getting lost, that is very common. Smoking. Yeah, people have had a habit for a long time. It's hard to smoke. If they could wear a patch, that would help, because smoking also works on a lot of physiological aspects of the body, and you want to curb as many bad ones as possible if smoking is bad for them. Firearms, that's a little scary. That's safety. You may want to be very cautious. Falling is probably a very high entity in elderly people. We try to get people in Tai Chi, which is a balancing exercise, to be able to learn how to balance their body a little bit better. Living alone. Well, living alone sometimes doesn't come easy, because sometimes that's the only way you can do it as well. Cooking depends upon how you cook. If you cook with a stove or an oven and stuff, that might be a little bit of a area that would have to be closely supervised. Sharp objects, again, safety. Safety is the highest point. So in what relationship are they using the sharp objects? Are they cooking with knives, trying to cut up their food and so on and so forth? Be very careful of that. Poisons. Poisons are anything household or whatever. If they swallow, ingest it, whatever, spill it on their arms or whatever, that might be a big problem. So be careful, and always have red flags and try to keep everything to a minimum. Inclement weather. If it's very, very cold out, if there's snow, ice, that can become a huge problem. In some of the northern areas, when it freezes on the first ice, people going out to their mailbox. They always have a higher incidence of falling down and hurting themselves, and being out there in the cold can be a large problem. Staircases and lack of ramps. Make sure staircases and the ramps are in good working order. Make sure that there's a handrail and so on and so forth. And make sure that the safety is well in perspective. Loud noises, nobody really needs a lot of loud noises. Some people listen to the TV set at a loud noise. Now they have hearing aids that are called streamers, and they can hook in these hearing aids and listen to the TV, as well as nobody is even listening because only they have the level of how loud it is, and it's not very loud outside. Sidewalks and accessible spaces, be careful. Some people don't walk well. Some people use walkers, crutches, and a cane. So try to assist them when possible, and especially getting in and out of vehicles. You'll have to have a vehicle that's low enough for someone to actually get in and out of. The taller trucks will probably have a problem. So other than that, I'll turn it back to you, Dr. Kirsten.
Thank you.
Oh, my next page. Did you want to skip that one?
Yeah, we are at the end of our presentation. Thank you very much.
Oh, thank you.
Thank you all for joining us today. So this is the end of the session, and it has been recorded, so it will be available to you all. Also, don't forget to take the evaluation that's been added to the chat. And on August 26th, there's a networking session. The first 100 that join will receive a Starbucks gift card. So thank you for attending today, and have a great day.